Okay, so moving on to section 6, we're going to talk about hemostasis. So this is the process of actually stopping bleeding if we have some sort of damage to our endothelial cells of our blood vessels. If we didn't have hemostasis or the series of reactions, we would completely lose all of our blood volume, even from the smallest clot. So being able to form these little platelet plugs are really, really crucial to maintaining our blood volume and actually not bleeding out. Hemostasis in this process is going to require clotting factors. There's several of them. They're numbered. You do not need to know the specific ones, or at least all of them. There might be a couple I want you to know, but I'll let you know during this lecture. There's 3 general steps involved in hemostasis. The first one's going to be vascular spasm. The second one's going to be platelet plug formation. And the third step is going to be coagulation, or the actual blood clotting process. So not every damage or nick we have to a blood vessel requires blood clotting or step 3. Sometimes just forming the platelet plug in step 2 is sufficient to stop it. If we have severe damage to a blood vessel, though, we would need to move on to step 3. Okay, first step, basically vascular spasm, and it is exactly what it sounds like. Your blood vessel is going to respond to damage or injury by causing vasoconstriction, meaning it's going to reduce the diameter of the blood vessel. If we reduce the diameter of the blood vessel, we're reducing blood flow to that particular area, which means we're going to lose less blood from that damaged site. So again, direct injury can stimulate the vasoconstriction. Also, chemicals that are being released by the damaged endothelial cells and platelets that are now kind of adhering or in that localized area. And even our pain reflexes can cause vasoconstriction. Really important that we have this vascular spasm step, even though it may not seem that important, because like I mentioned, it can significantly reduce blood flow until we have step 2 or another mechanism kick in. And it can reduce blood loss for anywhere from up to 20 to 30 minutes in order for us to move on to the next step, which is platelet plug formation. So like I mentioned, if we have healthy endothelial cells in the wall of our blood vessels, those are going to secrete nitric oxide and prostacyclin to prevent our platelets from sticking together. However, if we have damage to our endothelial cells, one, they're not only going to stop releasing or secreting those signals, which is going to start to cause our platelets to want to aggregate or clump together. Another thing is, if you remember from AMP1 in the tissue chapter, underlying all epithelial tissue is connective tissue. And one of the properties of connective tissue is fibers. So most of the connective tissue underlying our epithelial tissue is going to have collagen fibers. So once we damage our endothelial wall layer and we now have the exposed connective tissue, the collagen fibers that are being exposed are going to also cause our platelets to kind of cling or stick. Once we have our platelets kind of clinging or sticking to the exposed collagen fibers from the connective tissue, we'll have another factor come in, and that's called the von Willebrand factor, and it's going to help stabilize the platelet to the collagen fiber connection that we have there. Also, once we have our von Willebrand factor connecting our platelet to the collagen fiber itself, forming that bridge, we're going to consider our platelet then activated. Once we have an activated platelet, our platelet's going to become really large. It's going to get spiked and sticky, causing other platelets that are kind of floating by in our bloodstream to kind of stick and signal that this is the site of damage. And it's also going to cause the platelet to release some really important chemicals, 3 of which are ADP, serotonin, and thromboxane A2. Platelet plug formation is a positive feedback cycle. In AMP1, you talked about negative and positive feedback cycles, probably in chapter 1. I can't remember the exact chapter. But we have very little examples in the human body of positive feedback cycles. But the one that was mentioned in AMP1 was platelet plug formation, or the process of blood clotting. Because once you activate one platelet, what's going to happen is that platelet's going to do things like release these chemicals or cause other ones to adhere to it based off of its spikes, to cause more platelets to come and do the same thing. So that's the example, the positive feedback cycle. The other one I think that was mentioned in AMP1 was the release of oxytocin, which we'll talk about when we get to the endocrine system. Like I mentioned previously, for most small tears that we have going on in our blood vessels, because we have hundreds to thousands of these every day, the platelet plug formation is fine. We don't need to move on to this third step. In the event that we have a pretty severe damage to our blood vessel, we would need to move on to step 3, which is coagulation or blood clotting. It means the same thing. And basically what we're going to do in this step is turn our blood, which is pretty viscous, and transform it from a liquid into a gel. It's going to require our clotting factors, which we refer to as procoagulants. Most of these are going to be plasma proteins. They are numbered, so we do have clotting factor 1 through clotting factor 13 that were named in order of discovery, not in the order that they're actually utilized in the pathway of coagulation. You also need vitamin K in order to synthesize 4 of these 13 factors, and there's 3 phases to this last step. Okay, so phase 1 is basically trying to make sure that we produce the prothrombin activator. So we have 2 different pathways in which we can produce the prothrombic activator. In most cases, both pathways are occurring. There's just a difference in the pathways themselves. We can either have the intrinsic pathway or the extrinsic pathway. Intrinsic means coming from within, so the clotting factors that we need to activate this pathway are going to be found within the blood itself. When we talk about the extrinsic pathway, it means coming from outside, so the clotting factors that we need are coming from outside of the blood. But like I said, most of these, most of the time, in 99% of the cases, both the intrinsic and the extrinsic pathway are going to be activated. It's not usually one or the other. So I'm just moving on to the picture, and please don't get overwhelmed by all the clotting factors shown here. The only ones that I really want you to know are the ones that are involved in the prothrombin activator. So what you should get from this pathway is that, again, phase 1 of coagulation goal is to produce the prothrombin activator. How do we produce it? We have 2 pathways, one with clotting factors coming from within the blood. That's how it's going to begin, called the intrinsic pathway. One with clotting factors coming from outside of the blood. That's going to be the extrinsic pathway. We're going to go through a series of steps in which one clotting factor activates another one, and so on and so forth. We don't care about the numbers or the names of the clotting factors, but eventually they're both going to converge at producing the prothrombin activator. So you should recognize what the prothrombin activator is composed of. So it is clotting factors 10 and 5, represented in Roman numerals here, along with calcium. So collectively, those 2 clotting factors and calcium make up the prothrombin activator. Once we produce the prothrombin activator in phase 1, we're going to use it to activate thrombin. So we're going to take the prothrombin activator, convert prothrombin into thrombin. That's the whole goal of phase 2. And then we're going to take what we made in phase 2, which was the thrombin, and use it to convert fibrinogen to fibrin in our phase 3. And fibrin just is going to polymerize and form these insoluble fibrin strands that you can kind of see over here. That's going to produce a gel-like trap to help catch elements needed for coagulation itself. And here's the picture here. So we took our thrombin that we produced from phase 2, is going to come in and convert fibrinogen into fibrin, which is going to polymerize, and then we're going to be able to form our cross-linked mesh. Don't worry about all the other details. I really just want you to have a general understanding of the clotting process. And over here, this slide gives you kind of a good overview. None of the specifics in the middle are really that important. Okay, so we also have disorders that are related to our platelet number. These are usually going to be genetic-based disorders. So we have two major types of disorders. We have thromboembolic disorders, when we're producing clots that we actually don't want, so undesirable clot formation, or we can have bleeding disorders because we're not forming normal clots when we actually need clots to form. If you have both of these disorders, it's referred to as DIC, or disseminated intravascular coagulation. So just a couple terms, I would make sure that you recognize and understand the difference between a thrombus, embolus, and embolism. If we're talking about a thrombus, it's a clot that's going to develop and persist in an unbroken blood vessel. Okay, this can be a bad thing because it can block circulation, lead to tissue death, and depending on where it is, could potentially cause a stroke. An embolus is if we produce a thrombus and that thrombus broke free and is now circulating in our bloodstream. And then if we're talking about an embolism, is if we had that thrombus that was floating freely in our bloodstream and it glows and obstructs another blood vessel somewhere else. So somewhere like your lungs, so we would have like a pulmonary emboli or something like that. Other things, when we talk about thrombocytopenia, this means that we don't have enough circulating platelets in our bloodstream. So I mentioned before, we have thousands of tiny tears to our blood vessels throughout the day, every day of our life. And usually, if our clotting system is functioning correctly, then we're just going to go in and form those platelet plugs to kind of repair those small tears. In the event that we don't have enough platelets to form the platelet plugs, we would have thrombocytopenia, and we would see all of these small little hemorrhages, so all of these red spots that are referred to as petechiae. When we're talking about disorders related to platelets, a lot of our clotting factors are produced by the liver. So if we're not producing the amount of clotting factors that we need, it's usually indicating that we have some sort of liver impairment. Also, if we have vitamin K deficiency, because 4 of our clotting factors do require vitamin K in order for them to be produced. So if you have some sort of cirrhosis or hepatitis, again, related to your liver disease or disorder, you're likely going to have some sort of clotting disorder as well. So hemophilia is listed here. I'm not going to talk too much about this now because we do a lot with this, because like I mentioned, most of these platelet disorders are going to be genetic based. So when we hit our last chapter, chapter 29 on heredity, we'll talk a little bit more about hemophilia in that chapter. So hemophilia will not be tested on this first lecture exam. And like I mentioned, if you have both issues with clotting, it's just referred to as DIC, or disseminated intravascular coagulation.